there's broad class. I think we use psychotropics broadly. And I think there's a utility to that in terms of addressing the concern. And then you drill down, and some are antipsychotics, others are antidepressants, whatever the different classifications are. But, you know, in agriculture, we refer to agricultural chemicals as pesticides, but they're not all pesticides. Under that, you have different things. So I think it's important for us to get those subclasses, but I think there's going to continue to be a public and a media recognition that is psychotropic. And we need to also, as much as we might drill down and get more specific, there's still going to always be, I think, a public reference that understands them, broadly speaking.
But even, because I'm not sure if it's narrowed or expanded, because as you mentioned in your testimony, the notion of drugs prescribed for what purpose, and so that could even be broadening the scope compared from what we've been developing via legislation. So I'd like for our people to have conversations about that.
Absolutely. So in terms of, I think the other questions that you had, I think we've talked about this some, but obviously having information helps you understand what's going on. And we very much know that one of the challenges for this population, as we heard earlier, is they do tend to move around, or they might be mobile. One of the challenges often is they may come to a provider who may or may not have their history. So one of the things that we're hoping to do through this data sharing and such as well is also to help facilitate providers being able to have that information, so that they know that if they are prescribing something, it adds on to, as opposed to it's a standalone. And we recognize that that may be part of the kind of the system structural issue that is something that we can help facilitate as well. So as Director Kemp mentioned, we've also been working with the medical board and with other folks in terms of how to share data appropriately to look at this. We do also continue to work through the Quality Improvement Project, which was kicked off after the Mind Matters Symposium on the federal side several years back. And that has a number of work groups. So actually the data and technology work group's happening now. And so very much continuing that process with stakeholder engagement throughout those different work groups, includes clinical youth, as well as expert panel, and continue to advance that process and learn, and then be able to adjust and go from there. So very, very pleased to continue to have that interaction as well.
If I may, just from the social service perspective on a couple of the items, Greg Rez again from the Department of Social Services. I wanted to speak a little bit about what's happening once the data and information gets into the hands of the counties and ultimately into the hands of the social workers. What we've learned thus far is that counties are, as you might expect, are when the data comes to them, they have very specific information that's provided to them, which young person is on prescribed which medication, et cetera. They are using that to have conversations with those young people about their experience on the medication, and looking at other kinds of psychosocial supports that may be complementary or to that medication. So they're actually talking with young people, as we wanted them to do that. At the system level, a couple of counties that have large kind of data crunching facilities or capabilities are actually looking at prescribing patterns within the county, or kind of clusters of things, and so and they've been very appreciative of the data, as was described kind of at the last Child Welfare Council's meeting, because of the information that historically has been in the child welfare system included generic and non-generic titles, misspellings of medications, et cetera. And this has really helped them to identify kind of how big the bread box is, and then to work through it. So we're feeling optimistic about that. With regard to the Quality Improvement Project, the only thing I would add to what Dr. Scott said is that you may recall from previous hearings that the youth engagement group had created a pamphlet, if you will, for youth use for asking questions of their prescriber, of their doctor, of their social worker, of their caregivers relative to the use of psychotropic medications. That has been kind of updated in a kind of a youth-friendly format, informed by youth, for youth, and we also expect that our Office of the Foster Care Ombudsman will kind of use that as part of their dialogue with young people as well. If I have one moment, I could present our budget request as well, but I'm not sure if that's where we are in the agenda.
You might go right ahead.
Great. So,
Give an approval.
So our ask is twofold. We're asking for about $100,000 of general fund that's specifically related to implementing SB 238. These data matches and the data match and then the subsequent reports to the counties we've been doing within the department. We think that with the contract dollars, we'd more likely we'd be able to automate it. Clearly, we would be looking to do that with all the kinds of careful consideration that you heard about earlier relative to privacy and HIPAA requirements. Our first look is to potentially look at existing contractors we have that are familiar with the data, but clearly we're not opposed to looking at any contractor that could do the job on our behalf. The other request we have is related to SB 484. We're asking for limited term resources to support work in our licensing division. If you recall, this bill requires monitoring of group homes in a different way, more comprehensive way. These resources would be used to develop the methodology to determine which group homes to visit. It would also be used to develop the criteria for the visits and create reports and feedback back to the providers and to other interested stakeholders. So those are the budget asks we have related to psychotropic medication oversight.
Got it. Thank you. All these were in. Great. Elio, Finance. Any public comment on psychotropic medications, implementation of SB 238?
Thank you, Madam Chair. Senator Monty. Christopher Castrillo on behalf of the California Academy of Child Adolescent Psychiatry. Just want to thank you folks for the discussion with respect to antipsychotic medications and the difference between psychotropic. It is nuanced, and we are covering a pretty wide spectrum of medications there. To the extent that the Academy could be helpful in providing your office or in staff with that kind of information, we'd be more than welcome to do so. We're happy to do so, and thank you for that. Appreciate it.
Thank you very much. Okay, gotcha. Thank you. Let's move on to issue number 3, oversight out-of-county placements.
I noticed that in the staff write-up that there's some comments made about very little progress on this issue, and it's a long-standing issue, and we acknowledge that as well, and I'm sure there's much frustration around that. I'm going to try and give some perspective so that you can see clearly where we are headed with this issue. And I'm not going to go back 10 years ago, which I hear is when this first popped up, but I became involved 2 years ago when I joined the Child Welfare Council, and this issue was brought up and assigned to both DHCS and DSS to resolve. We did pull together a committee, a work group with DSS, CBHDA, the Child Welfare Department, or Directors Association, the Chief Probation Officers, and CSAC. In order to really talk through the issue. As we continue to work through and develop a work plan, AB 1299 was introduced, and the work stopped with the work group. There is a fundamental difference between the direction and procedure that 1299 is going regarding how to resolve this and what the consensus of this work group was. When we were surprised to hear that 1299 had stopped and had stalled out, we reconvened the work group and continued to provide updates with the Child Welfare Council. Our hesitancy to send out information notice is to see what happens with 1299, because we don't want to send out information notice that says the procedures are 1 through 3, and then 1299 by chance gets enacted and the procedures really are A through Z, which is going to cause a lot of confusion within the county. And so that's been part of the reason that the work has not been resolved. We have done a very comprehensive work plan, which I think we sent to your office. There are other items on that work plan besides just an information notice that we are working through and trying to get some of those other issues resolved. And so we'll continue with this work group. I did hear anecdotally this week that there may be some resolution within 1299, so I'm anxious to get the work group together to hear what the latest is on that process.
Maybe this isn't the process you utilize, but was in that the concepts contained in AB 99 contradicted kind of the work of the council? Was there any communication with the author of 1299 to identify that and try to either inform that process or provide clarity?
Yeah, there is a fundamental policy.
Oh, difference. Okay, that means.
It's the other side of a coin.
Got it.
Yeah.
Okay.
And I think, Karen has obviously been working more intensely with the various partners in the work group and as well as on the Child Welfare Council. I think what we fundamentally believe is that a decision that is agreed to by the broader group is a more likely successful decision. And so we are really wanting to have as many people both at the table as possible, but build the broadest consensus and agreement on a solution going forward, because that, I think, is what ultimately will resolve the issue. And so that's, in some cases, what we are continuing to kind of just work through in terms of wanting to make sure that we bring as many people and entities and organizations in support of the overall solution as possible.
So in the meantime, the mental health plan that has jurisdiction is responsible for providing these services or arranging for the provision of services. Where it gets complicated is when you're dealing with another county and there isn't a relationship between that provider and the county of jurisdiction. So we're trying to work through those. There is a dispute resolution process through Medi-Cal that beneficiaries can utilize, and then we also monitor calls into our ombudsman office, and if there were to be an issue that would arise to our level, that we would definitely have conversations with that county and provide technical assistance in order to get it resolved.
Okay. LAO, any comment? Finance? Public comment?
Good afternoon. My name is Wesley Sheffield, and I'm from Young Minds Advocacy. We're an organization that represents low-income children who have unmet mental health needs, and part of that population includes children who are placed out of county. I want to stress how critical of an issue that this is to resolve. 20% of all foster youth are placed out of county. We also know that these young people have more intensive needs than their peers, yet consistently over nearly actually 2 decades that we've known about this problem, they continue to get no access at all, or when they do get access, much less intensive services. And this continues today. One only has to look at the KDA service data to see pretty huge disparities between what out-of-county foster youth receive and what other foster youth receive. So we really urge the department, both departments, to find a resolution, because these are some of our most vulnerable youth, and continued delay doesn't do them any service at all. Thank you.
All right. So Ms. Baylor, as I look on the agenda, your name is on everything here. I'm not quite sure how we're going to do that in 45 minutes.
I am here as long as you need.
Okay, I'm going to try to go fast, but I don't know what you want me to do.
For me.
Okay. As I looked, I thought, your name is everywhere. This is your hearing, apparently. Sorry.
No,
I didn't
it's
want you
fine.
to.
I'm here as long as you need me to be.
My apologies,
And
thank
I'm a
you.
little offended that I'm sitting right next to her, and yet,
Director, you are not chopped liver, but let's be clear, but I don't think you were supposed to run the 3 o'clock work group that she was supposed to run, so you are certainly a welcome stand-in for Ms. Baylor. No question in my mind. Chopped liver, you're not. Ms. Baylor, you got me in trouble. All right, Department of Healthcare Services, we'll move on to item 4260, issues 1 through 8. We're going to start with the Community Mental Health Overview, page 10.
So let me just start by saying that DHCS is the single state agency for Medi-Cal, what we call Medicaid here in California. And DHCS administers the California Medi-Cal program and oversees the Community Mental Health Program. There is the Specialty Mental Health Program, which is covered under the 1915B waiver, which we're very excited to say that CMS approved for 5 years, the first time ever. But the system is what was called a carve-out system, meaning that it is run through the county system, and that the county mental health plans are responsible for providing or the provision of or arranging for specialty mental health services, especially to those who have Medi-Cal beneficiaries that meet the medical necessity criteria. There is also the Mental Health Services Act, which I'm sure you're well aware of. That we also are in close collaboration with the Oversight and Accountability Commission, so we're going to talk about some of those efforts later on the agenda. DHCS also manages a couple of the grant programs from the Substance Abuse and Mental Health Services Administration. One of those is called PATH, which is Pathways to End Homelessness, and so we monitor those as well. DHCS is responsible for doing triennial reviews, which means that counties get reviewed once every 3 years, and it is a full system review and a chart review. There is also the external quality review organization that reviews counties on an annual basis. And so part of the STCs that we received at the 1915B renewal, which is also another topic later on in the agenda, so we'll provide more detail of what those requirements are to make sure that we are now going to be posting and be a little bit more transparent with the oversight and monitoring of community mental health.
LAO, Finance. Any public comment on the Community Mental Health Overview? Seeing none, issue 2, 2011 Realignment Behavioral Health Subaccount.
I'm sure there'll be comments on this one. We have been working with the County Behavioral Health Directors Association and CSAC, and then through administration on looking at base and growth for the 2011 realignment account. We've spent a lot of time looking at base, and especially what we have looked at is a year's worth of claims, and to look at that and compare it to what the allocation was in that behavioral health subaccount. And as you recall, there are several buckets within that behavioral health subaccount. Seeing a trend over the last couple of years where counties haven't spent their full allocation, we have spent some time tweaking the methodology in order to align better the allocation and what is actually being spent. And we have done that in collaboration, as I said, with CBHDA and CSAC. I think we have finally reached a place where we are satisfied with base. We're working on an information notice that will go out hopefully soon. There were no changes to the base for this fiscal year, so we're talking about changes to base for next fiscal year and being able to set the base. We have spent some time talking about growth, but the majority of the conversations have been around base. CSAC has been very vocal in wanting some stability and predictability for counties, which we understand, and so the goal has been to be able to come to a place and methodology that everyone agrees upon where we can then set base that gives counties that predictability and sustainability. There is the growth amount for 14-15 growth. We've started to have conversations, as you know. We have received much feedback from others who have ideas on how to spend that growth. We also had a full stakeholder meeting back in October. Some of the challenges are that when you use money to incentivize, you really, in order for it to work effectively, need to tell counties ahead of time that these are the incentives. We're behind the 8 ball in doing that with this current pot of money. Yeah, for this. So we are having conversations with all those that I mentioned earlier to talk about growth. Those are ongoing conversations and haven't had any resolution just yet. But with the commitment that first call on growth be the entitlement programs as we've done in the past. Counties have not used all of their behavioral health sub-account money, which I've alluded to earlier. We have sent that information over to CBHDA. We're giving them some time to drill down and figure out why that is. So I don't have a response back to you on that, but that has been part of what we've looked at with base and trying to make those tweaks. But we didn't want to make such dramatic changes that it would really upset the county in what their spending amount is. We want to encourage counties to spend their full amount. So there is still conversations happening between us and CBHDA on what are the barriers for counties in spending that amount. Are there things, is there a fear, is there some reason that that's not happening? And I think that's...
And so I appreciate that that's the carrot way of getting to full utilization. Are you at a point now where you're thinking about the stick, as in the fourth question suggests, what will happen if they don't fully utilize the funds?
Right now, what happens is that that money is rolled over and they can use it again. I think that's part of why it took us so a long time to have the conversations regarding base, because we are making those adjustments. And want to continue to make those adjustments to where we get some sort of stability. But I think there is a consensus that making the tweaks that we are for 16-17 base will put us in a better position so that there isn't all the leftover money in the behavioral health sub-account at the county level.
LAO, Finance.
Thank you. Carla Castaneda, Department of Finance. We would just add, as the department is looking at the data to try to determine how the funds have been used, government code does allow counties to use the funds. It specifies the mental health services, the substance abuse programs that they can use dollars for.
I get that, but the point is we want them to use them right. Any public comment on the county mental health overview?
In the interest of time, since I have to be at that same meeting, Kirsten Barlow with the County Behavioral Health Directors Association, really just wanted to provide another point of appreciation for the administration, really working very earnestly over the past 6 months with us at the county level to really arrive at what makes sense approach to what each county's share of realignment revenue should be. There's a whole host of mental health and substance use disorder programs that are in that behavioral health sub-account, combined with Prop 63 and 1991 realignment. You know, we recognize that there are resources, but also a lot of pressures on the system, and really providing that stability and at least least at the county level, the ability to convince their boards to authorize hiring and to enter into contracts and things like that, because they can see the certainty going forward. Of course, we'll all have to be watching the economy since these are sales tax revenues, but at least having that certainty and not having to worry that from one year to the next, the administration or legislature might be trying to drive funding toward a particular program, particular population at a given time, and really giving the counties the resources they need. And as you know, behavioral health is really the only sub-account that since 2011 realignment has not had a permanent base set. There's always been this little footnote in the budget. So we look forward to having that stability so that we have one less thing to have to talk about, so we can really be looking at the program and developing the outcomes we want for the people who we're trying to serve. Thanks.
Thank you. Next witness.
Rusty Selix, California Council of Community Behavioral Health Agencies, and we certainly support the efforts the department has made to try to incentivize counties to increase care. But as you see from the data that has been shared by Young Minds Advocacy and California Alliance of Child and Family Services, it's not working. And the number of children being served, the amount of services being provided is stagnant. There's a lot of growth money that hasn't gone out. We think it's very important that the state establish clear policies that create stronger and clearer incentives. So in addition to reaffirming the incentive they've made about growth, I've got 4 or 5 other things they could be doing. And we've sent this out in writing, so I'll be very brief. First is they could offer money based on trends. If a county is showing the way it works right now, there's a whole year after the fiscal year ends before claims have to be submitted, and then after that, they allocate the growth, so that here we are about to start the 16-17 year, and the growth that was recently distributed is 13-14 growth. We could, as a trend line is emerging in the 15-16 year, send some of that out if they don't wind up spending for the full year, so that they're incentivized if they spend more. That goes out. Secondly, is you could create a pot for a plan to increase services, a pot of money for growth, that in order to participate in that pot, the counties are incentivized to develop a plan for how they're going to serve more children particularly. This is the sole funding source for EPSDT, Children's Medi-Cal, which is flat funded. I can't tell you how many times I continue to hear county officials who believe the funding is flat. Create a pot that is only for growth, and then in future years, as Ms. Baylor articulated, articulate the policy up front and then make it there. Third thing is there's a lack of transparency in the whole way county mental health budgeting happens. If you're a county employee, you can figure it all out, but if you're not, where is this money that has not been spent? And we have the same problem with Proposition 63 funds, Mental Health Services Act funds. That program is supposed to have a very open stakeholder process, and they hold an open meeting, but they don't put the dollars on the table. And the Department of Finance can't find the dollars, the Department of Healthcare Services can't find the dollars, the Oversight and Accountability Commission can't find the dollars, the providers can't find the dollars. Put all the dollars on the table, everything that you think you may have from past years and rolling forward, and then develop a strategy for how we're going to meet the unmet needs. It's an incredibly frustrating time for providers and advocates right now, because all the evidence is that the economy is strong and revenues are rising for counties, and yet the number of people being served and the amount of service being provided is stagnant. Something's not adding up, and we need the legislature to create a stronger and clearer process. Thank you.
Good afternoon, Madam Chair. Farah McDade Ting with the California State Association of Counties, speaking to this agenda item, which is the behavioral health growth and base accounts. I want to thank DHCS, HHS agency, and Department of Finance staff for working with us on this. We've had multi-hour meetings over multi-months for almost a year now. We are working as quickly as we can. We do recognize that there are areas that could use incentivizing, and we've been open to those discussions. I want to say that DHCS staff specifically has come up with some really interesting data and some good factors to look over, so that's really helped to inform the process. I do want to note that the system was realigned in 2011, and we've had many huge changes. We just spent the first part A of this hearing talking about AB 403. So those changes will have impacts on how the system responds. And so we've got AB 403, KDA, all these changes in the mental health system. That is why the base was not outlined in the 2011 realignment implementing legislation. That's why we are where we are today, still having some uncertainty. We appreciate that all stakeholders have heard our call for consistency and predictability. We look forward to moving forward with this issue. Thank you.
Wesley Sheffield with Young Minds, and I want to agree with many of the statements made by Mr. Selix about the importance of realignment funding to also consider policy goals and to create clear incentives and direction to the counties. While I can certainly understand the need for sustainability and predictability in funding, it's equally as important that, in particular for the entitlement programs, we ensure that young people are able to get the care that they need. We think in particular there needs to be greater attention paid to increasing access. We've seen the rates of children accessing care go down since realignment. We also think it's important to address pretty significant geographic disparities. A child in Fresno County, for example, is far less likely to get care than a child in San Francisco County. And we think that through realignment funding, the state can go a long way to help advance both access and equality. Thank you.
So going last, it's nice that people have already covered a lot of my points. I'm Dr. Linthal from California Alliance of Child and Family Services. We represent providers of children's services across the state. And so I do support the comments made by both Rusty and Wesley. I just also want to reiterate that this is a federal entitlement and the children aren't getting their entitled service at this point. Thank you.
Thank you very much. Appreciate that. We're moving on to issue 3.